It's an emotive topic, and we'll try and touch on some of those areas as we go through. So please do shout out if you have questions as we go along, because 90 minutes is an awful long time to talk about drug testing, so I might need some help here and there. So purpose of the talk today, we're going to look a little bit at the rationale for testing. Why do we undertake drug testing? Some specific drug testing procedures, the strengths and weaknesses of some of the different matrices that we use, and I'll cover the main ones this afternoon and talk a little bit about innovations. The context in which drug testing occurs, which can be very important, and then a little bit about the appropriateness of different tests for various clinical and legal purposes. So a bit of a whistle-stop tour of what is a very large subject area. And by the end of this afternoon, or the next 90 minutes or so, I hope that you will take away some information as well. So I've listed them here. Okay. So the rationale for testing. There are many reasons why we might want to test. Commonly seeking an initial diagnosis, so we want to check that the substance that our client is talking about is actually the substance that they have in their system, and to check to see whether there are any others. Screening may be undertaken as a requirement of a treatment program, whether that's to check for illicit drug use or to check for compliance with methadone treatment, for instance. You may use screening as an adjunct to a full drug history, so if you've taken a drug history from your client, then a urine sample is often quite a nice objective test to sit alongside that. In alcohol, we may look to screen for alcohol in terms of relicensing or checking with a breathalyzer to see whether or not substitution therapy can be prescribed. There are many medico-legal reasons and child custody cases, etc. Forensic purposes, where we might be looking at drink and drug driving, and as we've already heard a little bit, workplace employment screening has become very common these days, and indeed it's needed and necessary in our critical care or our critical safety environments, such as driving a train or flying an aeroplane or in power stations and the like. So for some areas it's very important. Could somebody just grab the door at the back? Thank you very much. And there is an awful lot of control and endorsement of drug testing, if you like. So there are international standards for drug testing in this country, in the United States, Australia, etc. So drug testing isn't just something that's done on its own in a laboratory in isolation. There are quality control systems that help maintain the validity and the correctness, if you like, of the testing procedure. And I think we would all agree, certainly in the field, that usually when you're trying to find out or investigate the substances that somebody has used, there is an initial test, and this is predominantly an immunoassay test, and this is followed by a chromatographic procedure, which is undertaken predominantly again in the laboratory, and this is the confirmation test. And we'll talk a lot about initial tests, immunoassay tests and confirmation tests as we go through the presentation today. So as I've just said, there are national, international quality control schemes, and with regard to the confirmation test, it's really gas and liquid chromatography attached to mass spectrometry, which is really a very sophisticated piece of kit that you find in the laboratory, and this is currently the gold standard that we have in terms of identifying and quantifying. Yes?
Sorry. Just wanted to check, social services in the UK
Yes.
do hair strand analysis.
Yes.
So would that come under the gold standard one?
Would it come under what, sorry?
The gold standard one? Hair strand analysis, which
Yes, if it was undertaken by it's really the equipment that gives the gold standard. So if the testing is done by gas or liquid chromatography, whether it's with blood or hair or urine, then it's the gold standard equipment. So yes.
Thank you.
And that enables a quantification of the drug in a fluid or a matrix, and that enables you to identify a specific drug, so the drug that's in the body. And generally, and we usually apply this to urine, but generally there are 4 possible interpretations of any test result. So we have a positive test, and that can be a true positive, so that means that we've detected correctly that the person is using a drug. Or we can have a false positive, where the person has not taken the drug, but the laboratory or your test has identified that the drug is present. And then you have the test result which is negative, and you correctly identify that the person has not taken the substance. And a false negative, where a person has taken the drug but the test hasn't picked it up. So it's not quite as simple as having a yes or no answer at the end of the testing procedure.
Sorry, can you explain that better? False negative
Yes.
means there's no sign of the drug, but he has actually taken it. So how do you establish that?
Well, I have some slides, so let me do false positive first, and then I'll come on to false negatives. And if I still haven't answered your question, we'll go back again. So for false positive tests, that usually means that there's an incorrect identification of a compound or a drug in the laboratory, or an incorrect interpretation in a sense, because the presence of morphine, for example, I'm sure many of you know, can give a positive test for legitimately for heroin use, but also from the occurrence or the ingestion of poppy seed bread, or the consumption of codeine if you take enough codeine. So you can get a morphine positive test from several different sources, so it doesn't indicate necessarily that heroin has been taken. There is legitimate medication that cross-reacts with your tests, so the amphetamine family is a good example here, where in some cases ephedrine and pseudoephedrine and cough medicines which contain amphetamine-like substances will give you a positive test. So again, you can't necessarily be sure that the person has taken illicit amphetamine or methamphetamine. And then there's also passive exposure. So if a person is in an environment where a drug is being used, such as the smoking of cannabis is the popular one, then it's possible that they may give a urine positive test. And I've just got an example here of some of the research that's been undertaken around that area. So 2 studies, a study of passive cannabis exposure where subjects were asked to sit inside an 8-man van, and this didn't give rise to false positive tests. So the results for THC, which is the main psychoactive substance of cannabis in oral fluid, didn't give a positive test. But then in those exposed to passive cannabis smoke in a Dutch coffee shop for 3 hours did give a positive test. So I think in terms of false positives and passive exposure to drugs, especially cannabis, it really is the extent of the exposure, the nearness of that person to the person smoking the cannabis, and the size of the room. So it is possible to get a positive test from passive exposure to cannabis, and so really the individual needs to be careful in terms of the proximity of them to the person that's doing the smoking. And with regard to false negatives, so that's what you were talking about. So chemically, some drugs, such as aspirin, can have an inhibitory effect on the laboratory process or the test process and cause a false negative. So it hides the drug that's there. So that's one possibility, although I think newer tests these days, and they're being developed all the time, are aware of some of these problems and have tried to address them. But the main cause for false negatives is if the laboratory or the test threshold is set too high. So if your cutoff for a laboratory test is, say, 100 micrograms per litre, and your subject, your client, has used drugs and has a concentration in the body of 50 micrograms per litre, the test won't pick them up. So although they've got the drug in the system, because the test cutoff is set too high, then they will have a negative test result. So that's a very important point to remember when you're looking at tests, is to make sure you know what the cutoff is and make sure that you've got a cutoff that's appropriate for your population.
I mean, it also depends on whether they're a fast metabolizer, for example, that change things.
Well, that's quite a difficult one. I think not always is the answer. So being a fast metabolizer isn't quite as an important clinical feature as I think we've come to believe. It tends to be quite transient. So it isn't something that happens to that person all the time, even though I know sometimes that's what the subject themselves believes.
Sorry, Professor.
Yeah.
For me as clinicians, how do we report false negative results if we're to carry out tests?
Well, sometimes the subject, your client will tell you that they've used the drug, and the test will come back negative. So that will give you a clue. I think it's making. If you know your client has used the drug and used quite recently, and your test is saying negative, then I think that then the cut-off level for that particular test is too low for your particular population. And if I think the next.
So, can it be used in law to prosecute? Can it be used as substantial evidence in law on false negative results?
Only if you've used another test to actually demonstrate that the drug is present, if that makes sense. Somebody's waving at the back.
The aspirin ingestion.
Yes.
With the immunoassay, which drug test, which drugs does it affect?
It's not necessarily the drug. It's mainly the immunoassay test kit which had problems. So some of the earlier EMIT immunoassay tests had difficulties with aspirin and paracetamol. It's because there is so much of the drug present that it swamps the process.
The urine drug screens that we use, I think it's chromatography. Is that what it uses?
It depends. Do you send your samples off to the laboratory, or do you just do them
in-house?
In-house, then that will be an immunoassay.
It's immunoassay.
We'll come on to those in a little bit. So again, a little bit about false and negatives relating to the subject of cut-offs. So if you look at this study, 17 healthy adults were given some raw poppy seed. All of the specimens that were then collected tested positive after half an hour, and remained positive for up to 13 hours after if used a 20 micrograms per litre cutoff. But if you used a druid one, which is a drug driving one, of what was their cutoff, was 95, I think. Yes, 95 micrograms per litre, so much higher, then that sample was only positive for half an hour. And if you use the SAMHSA one, which is an American cut-off recommendation of 40 micrograms, then your sample was only positive for an hour. So the message I think I want to get across is that it's really important that you understand what the cut-off is of the test that you're using. And immunoassay tests vary quite a bit, and make sure that it relates to your population. And if you look at, I think you can hopefully see that at the back, that if you're looking at clinical populations, the cut-off levels tend to be much higher. So if you look, there's 1,000 milligrams per litre as a cut-off for morphine. And the basis for the clinical cut-off is because they're assuming these people are addicts and therefore using a lot. if you have a workplace confirmation test, then for morphine or opiate metabolites, it's about 300. And that reflects more somebody who might be using on an irregular basis, but using nevertheless. So cutoffs are very important, and you just need to make sure that you know that that reflects your population, hopefully. So I'm going to move on a little bit now and talk about some specific biological matrices. So we can detect drugs in any tissue or matrices, really, from cerumen, which is earwax, to semen, and I'm sure we all know what semen is. So you can you can detect drugs in any kind of biological fluid. You can detect them in your nails, hair, etc. So it isn't that so much. It's the ease with which we can collect those samples which is important, and also the question that you want to answer. So bear that in mind when you're thinking about your tests for your clients. So I guess urine is the preferred biological tool. It certainly is for the laboratory because it's fairly easy to collect in a variety of different settings, and our drugs and metabolites are present in high concentrations because we've eliminated the drug from the body, so the analysis is quite easy.
Sorry, one question.
Yeah.
On urine tests, we
Yeah.
commonly use one, for example. Does diluting urine samples with water have an impact on the drug pressure?
Yes.
Okay.
So it dilutes your sample, so then it dilutes the concentration of the drug with the general aim of getting it below the cutoff, because our substance misusers are an intelligent population on the whole. They know as much about drugs as we do, if not more. They understand quite often the testing processes, and they know how long the drug stays in their bodies, etc. So they're an informed population in terms of drug testing, I think. So I've got some answers to that as well. So some drawbacks of urinalysis. The picture is often complex. Drug metabolites can be conjugated and made water soluble and then difficult to detect in our tests. Parent drugs may be present in very low concentrations, etc., etc. So sometimes it's the substance itself has a bearing on the type of analysis or type of matrix that we use. Cocaine, interestingly, is very labile, so if we collect a sample and leave it on the bench, allow it to be exposed to sunlight or particularly warm temperature, then cocaine will break down into its metabolite BZE. So we have to be careful in how we store and transport our samples as well. So as my colleague was just saying there, that sometimes the authenticity of the urine sample is a problem. It can be easily adulterated with chemicals, can be easily diluted, so there you have your false negative result again. And it can only indicate drug use over the last couple of days. So there are checks for the validity. If you ask the laboratory, they can check and tell you whether or not the sample has been diluted. They can check whether it's been substituted with anything else, another urine sample. Yeah.
So the temperature of the container containing
It should be warm to touch if it's just been recently voided, really.
I mean, if it's too cold, can that be? I mean,
If it's what, sorry?
if it's too cold, sometimes they.
I think it would be, if you've asked your client to go off and provide a urine sample and they come back and it's cold, I would be suspicious personally, because I think a bit like that. So, yes.
We do wear gloves, so sometimes it's difficult. I mean,
It is.
some
Again,
units
you
have a
can.
temperature thing.
Yes, some of the tubes do have a
Yeah,
temperature
some.
gauge, which are good. So there are lots of ways that you can tell. And also, if you're suspicious, you can ask the lab to check. In the laboratory, if they look at the specific gravity of a sample, then they can tell whether it's been diluted or not. So there are things you can do. And there you are. So sometimes the sample doesn't smell like urine. I don't know if many of you sort of take the lid off and smell it, but sometimes it doesn't, and that suggests that they've added something else to it as well. or they brought somebody else's urine in, which is a common trick too.
If we use a urine dipstick, that gives us the gravity,
Yeah.
specific gravity,
Yes.
instead of sending it to the lab.
Yeah.
Is that another way that's possible to find out if it's been diluted or not?
A dipstick.
Yeah, because it does give you the specific gravity.
Is that your, yes,
It
yes.
doesn't give you
yeah.
the exact one, like
No, but it gives you a
range,
guide, doesn't it?
If it is between,
Yeah.
you know. okay.
Yeah, I think anything helps. So that's urine sampling really in the laboratory. But as you know, that these days near-patient drug testing devices or POC devices are what we all use really, and we can use those for urine and saliva, and I'll come on to that in a little bit. So they are really helpful in that they can give you an immediate test result. They're near the patient, so you have you engage with the patient about that test result fairly quickly. But the important thing about these is they are all immunoassays, so they are all non-specific tests, and therefore that means that they only give you an idea of the type of class of drug that's being taken, so they won't give you any idea of the individual specific drug. And I think that's very important to recognise for an immunoassay test. Some of them are quite limited in their ability to detect drugs very well, so cannabis doesn't tend to come out very well in terms of urine immunoassays. As you can see, the accuracy varies really according to the different tests, and sometimes it can be up at 70% accuracy, which is what we want, and sometimes it can be down as low as 30 or 40% accuracy. And so again, ask about the type of kits that you're using, because there is a huge number out there on the market. Sometimes you will be able to find this from just Googling the manufacturer on the web and checking and just looking for specificity and sensitivity, and anything below 70-80% is not good, and ideally you should be looking for a test that's up there towards the 90%, especially if you're making decisions based on these tests.
When you're saying accuracy, is it sensitivity or is it specificity or is it?
It's a bit of both in this particular research, but so specificity is
because you want the first one, for example, the immunoassay
Yes.
to be very sensitive,
yes.
so you don't fail to pick something up,
Yeah.
and then you probably send it off to the lab to
Yes,
get more
exactly.
specific, right?
Yeah, exactly. So specificity is not so important because it's a class of drugs, so it's that common. Sensitivity, absolutely, you need it to be as sensitive as possible. But you can usually find out what the sensitivity is for the kit that you're interested in buying if you look at the product information sheet. That should give you the information. So things about immunoassays to take away: they're non-specific, they only give us an indication of the class of drugs. They're non-quantitative, so they don't give us any concentration of drug present. There may be cross-reactivity, so they pick up like substances, and screening is what they do really. They screen the urine sample and give a test result. They don't confirm the drug that's present in the body. So they cannot really be used in court and shouldn't really be used on their own if you're making definitive judgments about your client's future in treatment or helping to support him for a legal case or something like that. They only give you a guide. So interpretation of your test results, complicated because of the fact they're picking up different drug classes. A little bit there about labelling and accuracy, but I'm sure you know all of that. What I wanted to get onto, so this is an example of your benzodiazepines, big class of drugs. Your immunoassay picks up all of these types of drugs. So it picks up the metabolites, and it picks up different benzodiazepines that are prescribed within their own right. So you've got chlordiazepoxide there, you've got diazepam, you've got temazepam, you've got nordiazepam, which are all drugs within their own right and prescribed separately. But in an immunoassay screen for benzodiazepines, they will all give you a positive test result, and you won't be able to tell which drug has been consumed. And that's with your immunoassay test. If you use a chromatographic test in the laboratory, that will be able to tell you exactly which drugs are present. And it's exactly the same for the opioid family of drugs. So you have heroin over there on one side, and then codeine. Both of those drugs metabolize to morphine. We have dihydrocodeine, which is another commonly prescribed opioid. All of these will come up in your opiate immunoassay screening test. And again, if you look at the product information sheet, there's usually a section on cross-reactivity, and the company will tell you which drugs will give a positive test result for your immunoassay test. So yeah, just to conclude, so if you're taking, or if you have an opioid positive test from an immunoassay, it could be because somebody's legitimately taken medicinal diamorphine or morphine. It could be from illicit heroin. It could be from poppy seed consumption. These days there are specific immunoassay tests for 6-monoacetylmorphine. That's the intermediary metabolite which gives a strong indication that heroin has been used. So there are specific immunoassay test kits for that substance which you can purchase these days. And I thought it might also be helpful just to point out as well that there is a window of detection for your substances, and these are based on the consumption of one dose. So if somebody's using continuously, then obviously that will be reflected in their urine drug test. But if they take one dose of any of these substances, then this is how long you'd expect to be able to detect the presence of this substance in urine. So important to point out, it's varied, so it depends on the substance. Benzodiazepines are very long acting in most cases. So that's diazepam, for instance, will be around in the system for a very long time.
Excuse me, sorry to
Yeah.
If,
No.
if someone's been using benzodiazepines but they've come on a detox, and what's the time how long will it stay in the system? So you say 3 days. Anything beyond 3 days? Then
Yes,
you use it
diazepam will be around for longer than 3 days, I think.
weeks.
Yes. Well, it depends on the individual. The half-life of diazepam is about 40 to 100 hours, I think. So therefore what you usually do is you times that by 5, and that gives you an estimate of how long the drug will stay in the body. So it's quite a long time. Even if they've stopped, they're going to have positive urine samples for 10 days longer.
But not 6 weeks.
I wouldn't have thought 6 weeks. Yeah, I wouldn't have thought 6 weeks.
4 weeks is quite common.
Yeah, it's okay.
28
Yeah, it's okay.
Okay, so important thing that drugs do differ in terms of how long it takes for them to be excreted, and on the type of use. So if you've got somebody who's just used on a one-off, well, that's what they're saying, then it will stay around for much shorter periods of time than somebody who's using chronically. But I thought I'd just mention synthetic cannabinoids. So there are lots of these around. They haven't made it yet into routine drug testing. There aren't, as far as I'm aware, any immunoassay test kits, although I'm sure they'll be coming onto the market shortly. They're quite often lumped together and called Spice or K2, but there are several different types. They're all synthetic. They're sprayed onto herbal tobacco or the such like. And so they tend to go unnoticed in terms of routine drug screening. Picture a variety of different makes and manufacturers. The main thing is that they're very high potency, so they're much stronger than what we usually see in a normal cannabis cigarette. So the effects that come along with these mean that they tend to be much more acute. Your client tends to be much more disturbed, much more affected by these. They can be quite unpredictable, but again difficult unless the laboratory has specifically got chromatographic methods for these. They're quite difficult to identify, but their interest in them is growing, so hopefully there will be more laboratories that pick them up. But they are out there, and sometimes I think clients don't recognise just how much stronger they are than a normal cannabis cigarette. And I thought I'd just throw this one in because also there is a widening use of anabolic steroids. These are being used widely out there in certain areas of the general population. Again, they're not routinely screened for because people don't come into treatment very often, and the laboratories don't do them routinely enough. So you would have to specify and ask if you wanted to check this out. I think they're quite a hidden group in terms of usual run-of-the-mill treatment settings. And I just thought I'd add a little picture and cheer us all up on a Tuesday afternoon. So, concluding, urinalysis, so useful to confirm illicit drug use generally, or to give an indication of the drug class used. They cannot indicate the level of consumption, they cannot indicate compliance with dosing, or the time that dosing took place. So it really is a tool that we use for screening. We can confirm if we send the sample off to the laboratory to find out which drug is present. So reflects drug use over the previous few days, so it's not about what's going on now in the body generally. It cannot indicate impairment because it's a product of excretion and breakdown, so the drug is eliminated from the body, and that's what you're seeing in your urine sample. So really screening, use over the last few days just to check what's going on with your client. Blood, most useful in the opposite sense for quantitative analysis. It's used for therapeutic measurements, for toxic and fatal conditions, identifying very recent use, so we can accurately describe what the concentration of a drug is in the body at the sort of critical last 24 hours time, or even as now. And we can talk about how long a drug will stay in the body based on our blood concentrations, or what we know about blood concentrations, and a parameter called half-life. And again, as with urine, it varies according to the type of drug that there is, and the way that we work out how long a drug will last in the body is by looking at the half-life, and again timesing that by 5. If you want to be really sure, timesing it by 7. So there are some very short-acting drugs like cocaine that doesn't stay around in the body for very long, and then we have at the other end of the spectrum, where are we? Methadone, which we prescribe once a day and is a very long-acting drug. So lots of variability, but you should be able to calculate or estimate how long the drug will stay in the body by using these figures. And again, just wanted to pop in there about designer drugs. We know less about these than we do about our common illicit substances, even the ones that have been around for a while. So methadone has been around for a while now. We still don't know very much about the drug, because we know it's a stimulant, we know it belongs in the cathinone class, so it's a bit like cat. But because the people that use the drug don't come into treatment, or we are conducting research around the drug, then we know very little about the specific dangers or the pharmacokinetics of the drug. So there's a lot we still don't know. In terms of blood and any sample really, sample integrity is very important. The collection tube should have, for blood sampling, at least appropriate levels of a preservative and an anticoagulant in them. so that when they get to the laboratory, the drug has been protected and hasn't broken down. The sampling kit and blood collection tube should be of the appropriate standard. Attention should be given to the temperature and the light during storage and transportation, so some drugs will disappear. Cannabis, again, is very labile. If you take a sample with cannabis in it, if you don't store it in 4 or 5 degrees and don't provide some preservative, then it won't be there when it gets to the lab, or it won't be there in quite as high a concentration as it was when you took your sample. Timeliness of sample collection is very important as well, so if you're taking a blood sample, the longer you leave it between the incident or meeting the client or the toxic condition or the overdose, for instance, and the blood sample, then the drug will usually have diminished in its concentration and won't give you an accurate recording of the event that's taken place. There's a lot of information out there in the literature about screening for alcohol use. I think the most commonly used biomarker, if you like, is a liver function test called gamma glutatyltransferase, GGT for short. So this is elevated if your client is drinking more than 40 grams a week of alcohol. The downside, or the positives are it's a cheap, easy to use in the laboratory test. The downside is that there are lots of other things that cause elevation of gamma GT, numerous other drugs, for example, diseases, high blood pressure, diabetes, smoking, etc., etc. So it's a good test if you know your client is drinking, to confirm that they are drinking at dangerous levels, but it's not always good for picking up people who you suspect are drinking but who are denying that fact. This is another test, so MCV, mean corpuscular volume, again elevated by the toxic effect on our red blood cells. It's a slow to change tool, this one though, so you have to be drinking at high levels for at least 1 month before you get an elevated MCV, and it's slow to come back to normal if you stop drinking, so it's not very good in terms of using it just to find out quickly what's going on with your patient. And just to remind you, 1 unit of alcohol is 10 mils or 8 grams, or 1 unit, yes, of alcohol. So I think sometimes we forget when we're talking about grams of alcohol and tests requiring consumptions of alcohol above a certain limit for the day, that these have been around for a long time, and so the where's the half? So half a standard glass of red wine was based on actually 125 mils, so that was what a unit was. These days our glasses are 175 mils, so actually they're more than 1 unit. But again, it's useful, I think, to work out with your clients whether they know what they're drinking in terms of units, because that will give you an idea of the level of their drinking. And if you look at this, you can see that it's fairly easy if somebody's drinking on a daily basis, or even drinking 2 or 3 times a week, if they're having 4 or 5 pints, or if they're having a good bottle of wine, then it's very easy to be drinking over the recommended limits, which are 14 units for men and women equally in the new national alcohol policy. So just bear those in mind when I'm talking about the biomarkers. So liver function tests, the other 2 that we commonly see are AST and ALT, both liver enzymes, really looking at generalized damage to liver cells, and they're really not very good to use on their own. So people often use gamma GT, MCV, AST and ALT as a group of liver function tests to try and get an overall picture of what's going on in terms of alcohol use. And a more recent one, it's been around for a long time, but it's not being used very often in this country, is carbohydrate deficient transferrin, which is thought to be much more accurate in terms of picking up continuous drinking, even when somebody is denying the level of drinking. It's shorter acting than the other tests, so it's, yeah.
Just going back to AST and ALT, is AST elevation more than ALT elevation?
Yeah, they're not. They don't behave exactly the same, but we use them together with MCV and gamma GT. So if they're elevated, or if one's more elevated, I think that would be a normal pattern. But I wouldn't recommend you use them on their own in isolation. So CDT is increased mainly and only when it's exposed to alcohol. So there are very little other features of this test which are affected other than alcohol use. And as I say, it's 14 days. It returns to normal after a couple of weeks if the patient is absent. So it's used in this country for high risk, for the high risk drink driving population, for licensing purposes, and very successfully. To get elevated in the first instance, you need to be drinking more than 60 grams of alcohol for a couple of weeks. So you do need to be drinking quite a lot to get above that level. Okay, so benefits of blood tests. So blood properly collected.
Can I ask you about that last one?
Yeah.
How specific is it? You said it's very, very specific. This is
It's only got glycoprotein disorders, which are quite unusual and rare and usually diagnosed. And then there are some genetic variants, D in particular, which is also can be picked up in the laboratory, which may cause an elevated sample. There are very few other specific things that cause an elevation of CDT.
Thank you.
So benefits, as you might imagine, it's quite difficult to contaminate and adulterate blood sampling. Main thing to remember with blood testing is a valid and reliable chain of custody, particularly if it's a sample for a legal case. And in human anti-doping, for example, they have a specific system where they collect two vacutainers. One is called the A sample and the other is a B sample, and the laboratory has one and the athlete has the other, just to ensure that they can have that tested in a laboratory of their choice if they so wished. So there are lots of ways that we can ensure that there is a chain of custody. Downside of blood, obviously, blood collection requires trained personnel. It's an invasive procedure. There is a risk, although it's small, of needle stick injury. Very difficult to collect in terms of large volumes, and some addicts may have very poor venous access, so it's not the easiest area to be in. Innovations in this particular area, so there is a growing interest in dry blood spots or small liquid samples, based on the idea of the Guthrie test, the heel prick test that babies have. So you collect a sample either from the heel or from a finger. It's much simpler. I think it's the practicalities of using what will be a little paper disc and managing that in terms of drug testing, but there's lots of development going on, and illicit substances have been detected using these processes. There were, so the Centre for Disease and Control Prevention in the USA has a list of a large number of substances that have been measured by dry blood spots, and there are commercial companies looking at it, so you imagine in 5-10 years, so this will be another bit of the armoury for drug testing. Moving on to oral fluids, so probably used more than it was 10 years ago, so very popular now. Saliva is a key constituent. Relative ease of sample collection, reduced susceptibility to adulteration, so lots of positives. The other positive, it reflects the free drug in the body, so it's more easily related to blood than it is to urine. And from what the research says, the general population prefers to give an oral fluid sample than either a hair sample or a urine sample. So it seems to be more easily liked out there too. There are a number of factors which can impair our ability to sample. So if you are collecting a saliva sample to send to the laboratory and you are using a salivette or a specific collection tool, then sometimes people have difficulty in producing enough oral fluid to enable drug testing to take place. So there'll be some of you in the room like me who started to salivate already because you're a salivator. There are others for which salivation doesn't come very easily. There is a condition, xerostomia, which is a subjective feeling of dry mouth, and that's out there in the population. There is also salivary gland hypofunction, so that means you're not producing the normal levels of saliva. So there's a range of abilities in terms of the population being able to provide enough oral fluid for a test if you're sending it to the laboratory. And lots of our drugs of interest have an impact in terms of affecting or inhibiting salivation. In terms of specific drugs, so cannabis is a popular test in oral fluid. THC is the predominant analyte found, and there's always usually a but, there's some debate about whether we actually excrete THC into oral fluid, or whether it's there because it's been there because we've smoked cannabis and it's contaminated the oral cavity. We can find cannabis or THC in the naso-oral cavities following smoking, so it's difficult to say which is which. There is a pattern though, so we do see very high levels of THC recently after smoking, as you would expect, but it falls fairly rapidly. So if you collect your sample 4 hours after someone has smoked a cigarette, then the levels are going to be very low indeed, although they persist in oral fluid for up to 12 hours. So low levels in oral fluid, but they do persist over a period of time. Screening for cocaine, also successfully done in oral fluid. So again, immunoassay methods. So most immunoassay tests test for both cocaine and benzoylecgonine, the BZE, the main metabolite. Some are designed to pick up BZE more prominently because they recognise that cocaine is very fast acting, so you may not pick it up, but if you pick up the main metabolite, you've still got evidence that cocaine has been used. So again, it's back to the question that you want to ask: are you looking to specifically find cocaine above a certain cutoff, or are you looking to show evidence of cocaine use in the past, and so the main metabolite BZE will do? So again, most commercial assays will cross-react with cocaine and benzoylecgonine and other metabolites of cocaine actually. So if somebody's using regularly, you will find that your immunoassay tests remain positive for a lot longer. Oh, and a picture. This is the downside of cocaine use. Screening for opioids, again, same problems of interpretation that you get from others. There is a slight advantage since the detection in urine of 6-monoacetylmorphine, the primary or the intermediate metabolite of heroin use, is actually found more often in oral fluid than it is in urine, so oral fluid is better if you want to pick up heroin use. And some metabolites, some drugs that are opioids, like your oxycodone, your hydrocodone, actually are present and easily detected in oral fluid. So again, you can get specific oral fluid screening tests for 6-monoacetylmorphine to specifically pick up heroin use. Even though we've said immunoassays aren't used generally for confirmation tests, oral fluid confirmation using oral fluids has been used in Australia. This is in the drug driving arena. So in the state of Victoria, they do random roadblocks to pick up drug drivers. They conducted 300,000 or so tests over a period of 6 or 7 years or so. They pick up and test people using a drug wipe immunoassay test, and that screens for the 3 drugs that you can see there. And then if that is positive, they collect an oral fluid sample using a second device, which is the COSART, and that is sent off to the laboratory for testing. So they're still requiring a laboratory to confirm, but they're using a sampling device at the roadside to do that. And oral fluid screening in the workplace. So there's been a lot of work done in this area, particularly for workplace drug testing, and there are lots of bits of kit out on the market in terms of oral fluid collection devices. Some are better than others, excuse me. And the important thing that's come out of the work that people have done is that if you're collecting oral fluid, you need to know what the volume is that you've collected. Otherwise, it's very difficult to quantify the drug in the laboratory. So this has been mandated now within workplace drug systems, so that if there is a specific cut-off, and it's quite often 15 nanograms per mil for cannabis in the workplace, for instance, if the laboratory has to provide evidence that it's 15 or above, then they require the collector to make sure they know how much oral fluid has been collected. And there are some devices which tell you how much has been collected, and there's a little dye or a colour change that indicates when you've collected enough oral fluid. So again, depending upon what you want, the question that you want to answer when you're testing, it's important to know that you've got the right piece of kit to be able to do that, so that the laboratory can do its bit. So near patient drug testing kits are really the most commonly used form of drug testing using oral fluid these days. Huge amount of information out there, and lots of different tests. Again, read your read your performance indicator or the information leaflet for your test, because that will give you some of the information that you need. They remain non-quantitative, they remain non-specific. Generally, unless there's a system like the one in Australia, they're not able to provide confirmation tests. You need the laboratory for that. Moving on to hair testing, a further option. You can use it for confirmatory drug testing. You just have to bear a few things in mind. It's very good in terms of having a longer time scale, so 1 to 3 months or more, depending upon the length of your hair. And it's generally thought of by many to be a more dignified collection process, but you do have to collect several strands of hair. And it's a less risk of infection, etc. So most of the drugs that we would wish to be detected in hair have been successfully detected in hair, so it's a wide-ranging piece of kit. But, and there's always a but, the analytical procedure for getting your drug out of hair is very sophisticated. It requires specialist knowledge. So not all laboratories offer hair testing. In fact, very few do. And therefore it tends to be a bit more expensive, I would say. The analysis is not straightforward, and there are also several sources of error and misinterpretations that you might need to be aware of. So, for instance, we still don't know too much about the way in which drugs are incorporated into hair, but we know it takes about 5 to 7 days. So if your client has taken a drug, it's not going to be visible in hair for about a week. It takes a while for it to get there. And we're not sure of the route of entry. And also there's the influence of the hair growth cycle. So your hair usually grows at about 1 centimetre a month. It might do that for several years and then stop and have a rest period. So sometimes that's important, sometimes it's not. Melanin in hair is important, so the pigmentation that you have in hair is thought to be important in determining the amount of drug that's deposited. Some evidence there is racial bias in hair analysis, and I think there's an example. So if you look at the study here, Caucasian versus Africoid subjects, the Africoid subjects had higher cocaine concentrations than the latter. And it's generally thought that basic drugs have the highest incorporation rate, so opiates, amphetamines, cocaine, into hair, whereas acidic drugs like aspirin, for instance, really don't get into hair at all. And cannabis, which always seems to be quite problematic as an analytical substance, is particularly difficult to detect in hair, although there are methods that have done it. So false positives, again, so passive exposure to drugs can be picked up on hair. Most laboratories now have washing procedures to overcome this, so they wash the hair before it's analysed. Common hair treatments, particularly peroxides, and which may alter the hair strand, may also have an effect and damage or destroy the drugs in the hair. The biggest practical limitation is, of course, the length of hair. A closely cropped hair style will not have the same amount of drug in it as somebody who's got long hair. And studies that were planned to be done in prisons were thwarted somewhat by the fact that most prisoners have their hair, or this is an Australian study, in the study many of the prisoners had really closely cropped hair, and so it was difficult to get a sample. And in terms of the sample,
can't you use armpit hair or pubic hair?
You can, but it's difficult to get quite enough, and also if you're thinking about armpit hair, it's difficult to tell the cut end from the end. So when you collect a sample from your head, you note the end nearest to the scalp, because that will tend to have the highest concentration of drugs, and less as it grows away from that. So if you have armpit hair, you really would struggle to find the cut end. And pubic hair would be different, but it's not the easiest of samples to collect in sufficient quantity. Yes? Although it is done, I have to say, in legal cases, pubic hair is often collected if they can't collect from the head.
Is the hair strand analysis, is it qualitative, quantitative, or both?
It tends to be quantitative. It's because you can only analyse hair using a chromatographic method in a laboratory. That tends to mean that you can quantify it, unless the drug is at very, very low levels. So you do need a lock of hair, 1 to 3 centimetres in length, 30 to 50 strands. There is science out there that is looking at drug analysis from a single strand of hair, but the concentrations that we're talking about are very, very low. So the normal route is to collect 30 to 50 strands of your hair from the crown of your head. There we go. So again, international guidelines do exist, and standards for testing of alcohol testing and drug testing. So it's quite a standardised process now. Most workplace guides that use hair testing have policies in place that suggest that you have to let somebody know a month beforehand to make sure they have a head of hair that can be sufficiently sampled. So it's established as a drug testing procedure out there, and it is successful in terms of providing information about specific drugs. Used for opioid fatalities, so methadone was detected in 97 odd fatalities, 6 MAM detected in another 30. Compared to blood, only one sample was positive for 6 monoacetylmorphine. So hair really gives you a history of use rather than the recent what's going on now. So it's historical, and that's where its usefulness lies. Little bit about ketamine. It started out life as a veterinary drug. It's now used widely in medicine, in pediatric dentistry, for anesthesia. So it's a widely used drug medicinally, very successfully used, but is also very popular these days as a drug of misuse, taken in lower levels than we use for anesthesia, obviously. But it has a stimulatory as well as a hallucinogenic effects. It's found in its own right. It's no longer mixed up with the ecstasy tabs and capsules that they were. So it's a drug that we begin to see in drug using populations, but it's not a drug that has found its way onto the routine drug panel for tests. So again, laboratories will only test for it if you suspect it and ask for it, as I've just said here. So it's found easily in hair. It's something that the laboratory can easily measure using chromatographic techniques. So it's not that there isn't the ability to analyse and detect this substance. It's more that it just hasn't made it onto the routine standard panel for drugs when we talk about illicit substances. So uses of hair analysis, again, can establish over a period of time drug use per se, used a lot in post-mortem examination and used very successfully in legal work. So for parents, for example, who wish to establish that they haven't used drugs over a period of time, a hair sample is useful in that regard. Fetal exposure to drugs, so you can sample a newborn's hair to check the extent of drug exposure during pregnancy and child protection case. So it's a widely used matrix. And then we're getting to the end now. Exhaled breath. So predominantly I think we always associate the breathalyzer with alcohol use, engaging alcohol consumption, and that's well established, I would say, internationally as a tool. There was some early work looking at tetrahydrocannabinol, so THC, in terms of whether we could use detect that in breath. And I'm pleased to say the field has moved on a great deal. So there are now procedures and processes for the detection of drugs using breath. There are various different techniques, and commercial sampling systems are on the way, if not already. They're certainly being used in research studies. I've got a box of this device. It's a device that's used in Sweden. It's a little kit that you can actually put together, and you blow, I don't know if you can see, there's a bag here, you blow into the blue device and the air sample is in a bag, and the bag is taken to the laboratory and you analyse the air. So successfully used in Sweden for a number of different drugs. So things are beginning to move in terms of the different types of tools that you have for drug testing. Here we have an example of cocaine detection in breath, so 10 individuals given an intravenous dose. Not many, interestingly, of the sample were positive for cocaine, more for cocaine than benzoylecgonine. So I think it is possible to detect cocaine in the breath of individuals. Methadone has also been successfully tested and detected in the breath. So it's something to look out for. I think drugalizing, or whatever we're going to call it, will be something that we'll see more of in the future. And then just a little bit about sweat drug testing. So again, this was very much a matrix that was used in the States to identify drug use in prisoners, either by passage of fusion of fluids through the skin or glandular secretion, the process of sweating. And it didn't really take off because there's a lot of issue with topical contamination. It's a patch and you can fiddle with it, for want of a better word. But there are quite a few, and they're certainly well established in the populations that they use. So Farm Check is the most commonly used one. Other devices are out there. The Farm Check, the gauze is, the patches tend to be worn for at least 24 hours and then for between 7 to 10 days, and they go on your upper arm or on your torso somewhere. But if you think about showering and putting moisturiser on and that kind of thing, you can easily contaminate them. But in a prison setting, they've been used quite successfully to monitor drug use. A more recent introduction has been the drug wipe, which is it's the same kind of kit that the police use for drug driving over here. So the drug wipe have produced a sweat testing device where you wipe the device on your forehead, and that will again give you a immunoassay test for various different drugs. So it's been used successfully for methamphetamine. And again, I think what we're seeing is an explosion of different types of methods for drug testing that's moving away from the bog standard urine testing, and also perhaps moving away a little bit from immunoassay test kits and looking at other devices and other procedures to try and expand the repertoire of the people that are using them and perhaps meet some of the questions that people have. Haven't talked very much about benzos today, but you can obviously collect and detect benzodiazepines in all the matrix we've talked about, and that includes sweat testing as well. So I think as we go forward, we will have a bigger choice of tools to detect drugs from. Sweat testing, it's been used successfully to check on abstinence. Again, used extensively in the United States for the criminal justice system, used in European countries for drug driving. So it's a tool that's out there. We've talked a little bit about the gauze and the sweats. I'm not going to concentrate too much on that one. I just wanted to move towards the end and talk a little bit about latent fingerprints. So this isn't to be confused with the fingerprints that you give in a custodial setting where you've got ink and you present a print of your fingerprint. This is latent fingerprints where you're actually sampling what it amounts to is the sweat on your fingers. And it's a growing tool again, much research being done. It's worked very successfully for methadone, for cannabis, cocaine, methamphetamine, etc. And lots of different groups around this country, but also in China and Japan, are looking at the utility of using a latent fingerprint as a drug testing device. Because again, it's non-invasive, it's easy to use. If you can get a test result fairly quickly, it seems a lot cleaner than collecting a biological fluid for all those reasons. So highly applicable to different avenues of needs of testing, so from roadside to workplace, anti-doping, etc. But, there's always a but, contamination may be a problem. So contact transfer, so if you are in an environment where you come across drugs, you can transfer the drug via your hand from the table or whatever, and contaminate yourself or your fingerprint sample. And then the parent drug is transferred onto the skin through handling deliberately or accidentally as well. So there are ways that you can contaminate your fingerprint. But I thought you might just be interested to see. So this is, and it's bizarre the lab chose green for methadone. I thought, without realising that that's the colour that we prescribe it in generally. So the white specks for the, I don't know if you can see them, the white specks are actually methadone detected on a fingerprint, and they fluoresce the fingerprint a different colour so that they can see the drug. So again, it's not a quantitative measure, although I think various people are researching that. So it's non-quantitative. It just tells you whether it's there or not. But it can pick up specific drugs. And this one is a cocaine metabolite, so benzoylecgonine. So again, easily picked up on your fingerprint. So a whistle-stop tour. In general, blood is likely to give still the most accurate measurement of drugs currently active in the body. Oral fluid is a near second, I guess, in that regard. Urine is and always will be out there as a reliable tool, providing you take the authenticity of the sample into consideration. It gives you a broader time frame, but less quantitative accuracy. Hair has the longest detection window. It's very useful if you want a historical picture of drug use. It can be very accurate, so it's quantitative. But I keep an eye out for innovations. It's a very fast developing field. It's being applied and used more widely everywhere, so I'm sure the field won't stay as it is. So I have no idea where we are in terms of time, but that's me done. Thank you very much. And any questions? Yes?
The drug driving law in the UK, they do roadside testing.
Yes.
So are they using oral?
Are they what, sorry?
Are they using the oral fluid?
They're using the drug wipe or the Draeger, so it's oral fluid, yes, and it's an immunoassay test. And if that's positive, then off you go to the police station to give a blood sample.
By default, all immunoassay qualitative.
All immunoassays are non-quantitative. They're qualitative, yes, they are, yes.
And gas chromatographies are quantitative.
Yes,
Thank you.
yes.
Two
Hi.
questions. Thank you very much. Excellent talk. I've enjoyed reading many of your published articles and actually hear you live. Thank you. What, in your experience, is the longest time that benzoylecgonine could be detected? I have patients who have no reason to lie,
Yes.
and they have reported it's close to 2 weeks, maybe in excess of 2 weeks, when that test, not cocaine, the metabolite is there.
And is that just after a single dose or somebody that's been
These-
chronically using?
I deduce it's if they've been using daily until they ceased.
Yes, and then it's
Could it
2
possibly exceed 2 weeks? Because there are things posted on the internet saying that. Of course, that misinformation is
Yeah.
what the addict loves to read.
Yes, they do. I mean, I think what they're probably seeing is that the immunoassay test picks up lots of different cocaine metabolites, not only BZE, and that tends to lengthen the time in which the drug is positive. So you may get, yeah, I think that is often the reason why there is an extended window that's being reported. But having said that, benzoylecgonine, as I'm sure you know, is much longer acting than cocaine. So there are reports that it's around for a long time. I haven't seen any that say up to and beyond 2 weeks, I have to say, but I wouldn't be surprised if it was around for at least a week or so if somebody's been chronically using it.
I have another question.
Okay.
You didn't comment on it, but could you just speak very briefly about fentanyl?
Well, dangerous opioid, very, very powerful, 100 times stronger than morphine.
But in terms of detection?
In terms of detection, again, I think you would have to check your individual immunoassay kits to see whether it cross-reacts with other opioids. I'm not sure that it would.
Seems to get a false positive with trazodone.
Yes. So it does, so the different tests, the different immunoassay test kits will have been set up with a different antibody, so they won't all function in the same way, so some may be better or worse. at detecting fentanyl, but it isn't a drug that people would routinely look for, as I'm sure you know. Are you seeing fentanyl?
A lot.
Yeah, really?
A lot. But if there's no fentanyl, that's almost confirmation that it's been metabolized.
Yes, yeah. Okay, yeah.
At the moment, are there any screening tests for synthetic cannabis?
Part of me wants to say yes, I'm sure there are, because I'm sure if you look, somebody will be developing one as we speak, but I'm not aware that they're out there on the market in the same way that we have immunoassay tests for cannabis or cocaine. So synthetic cannabinoids tend to be measured by chromatography in the laboratory.
I mean, the police, when they use the oral fluids, I don't think they have any club drug or synthetic cannabis testing.
No, they don't.
It's just the basic ones.
No, and synthetic cannabinoids are not usually detected on your basic cannabis immunoassay drug screen. Okay. All right. Thank you very much, everybody. I'm not sure that it would.
Seems to get a false positive with trazodone.
Yes. So it does. So the different tests, the different immunoassay test kits will have been set up with a different antibody, so they won't all function in the same way. So some may be better or worse at detecting fentanyl, but it isn't a drug that people would routinely look for, as I'm sure you know. Are you seeing fentanyl?
A lot.
Yeah, really?
A lot. But if there's no fentanyl, that's almost confirmation that it's been metabolized.
Yes. Yeah. Okay. Yeah.
At the moment, are there any screening tests for synthetic cannabis?
Part of me wants to say yes, I'm sure there are, because I'm sure if you look, somebody will be developing one as we speak, but I'm not aware that they're out there on the market in the same way that we have immunoassay tests for cannabis or cocaine. So synthetic cannabinoids tend to be measured by chromatography in the laboratory.
I mean, the police, when they use the oral fluids, I don't think they have any club drug or synthetic cannabis testing.
No, they don't.
It's just the basic ones.
No, and synthetic cannabinoids are not usually detected on your basic cannabis immunoassay drug screen. Okay. All right. Thank you very much, everybody.